Hi, hello, and welcome to this closing plenary session, otherwise known as Sex, Drugs and Scotland's Health. My name is Pennie Taylor, and it's my great privilege to be your chair for the next hour. You're going to hear from a number of speakers, and there's always the opportunity for you to put your questions related to anything you're hearing. Please put them in the Q&A column to the right of your screen. Without further ado, I am going to introduce our first two speakers, and then I will move on. We have Alistair Hudson, who's the interim chief executive of HIV Scotland, and he's co-host of the conference alongside his our other speaker, Dr. Ingrid Young, co-chair of this conference and based at the Centre for Biomedicine, Self and Society. She's written widely and she's worked on sexual and reproductive health in Scotland for 10 years. Before I introduce our other speakers, I wonder if you could take it away and give us your thoughts. Thank you.
Do you want to go first, Alastair?
Well, you go.
Okay. I'm gonna keep this brief because everyone has heard quite a lot from me over the last 3 days. But this is really just to say, this has been a fantastic conference. It's been a long time in the making, COVID notwithstanding. But I've been really pleased that we've got here, that we've been able to spend 3 days with. It's the first time in quite a few years we've been able to come together as a sector to really address and to engage with each other around the challenges that face us in terms of sexual and reproductive health and social justice. And I really have enjoyed and found really powerful and moving a lot of the sessions that have engaged directly with these issues. And I'd really like to flag up the kind of the roundtable discussions on trans health, on migration, on racism, but also the other sessions that have taken place around consent, the drug deaths and chemsex roundtables. And I think there's just so much for us to engage with. We probably easily could have made this a 6-day conference or a 10-day conference, even though that probably would have killed us all. So I really see this as the beginning of, or continuing on, conversations between academics, third sector, community health practitioners and others to really address some of the underlying structural inequalities that face us, to think about how we can really come together as a sector to be creative in our response to the contemporary challenges. And I think we've got lots of really fantastic building blocks and some really fantastic ideas and people willing to put in the work. So I just really wanted to thank you so much for your time that you've put into this conference, to your research, to your practice, to your sharing your experience and your expertise with us. And I look forward to working with quite a lot of you in future. Even if I can't physically see you on the screen, I know that you're there. So thank you very much for your time, and I look forward to working with you. And I'll pass it over to Alastair.
Thank you, Ingrid. It's been an incredible couple of days. I feel deeply honoured to have worked with Dr. Young and my team, Becky and Gavin at HIV Scotland, Irish Nurse Steering Group, and our sponsors, Gilead Sciences, Vivo and Mumford, and Public Health Scotland, who have all come together to produce this small but mighty conference, and thank everyone who's come along for the journey. What 3 days it's been. It's been humbling, invigorating, exciting, and I've been reeling in equal measure. So many emotions over the last few days for everyone. I choose to believe when we know better, we do better. This conference has given us all great opportunities to share, reflect and learn from each other, meet new colleagues, old colleagues, people we're going to work with in the future, including the two young people who are going to speak at the end, or people who are just beginning their careers in this mad, mad game called sexual health and well-being. I left Glasgow 33 years ago, where it was a sin was one of the kinder ways to describe same-sex anything. Coming home to a country that in 2014 legalised same-sex marriage was unimaginable. No, seriously, it was unimaginable when I was younger. And in 2017, seeing our First Minister apologise on the telly on behalf of the Scottish Government for historical convictions of gay men was a game changer. Suddenly it felt safe to come home again. But there's still much to do. We know this, and certainly over the last few days, we've got much to reflect on. Over the last 3 days, we've heard from each other, shared data and evidence about where the challenges, new and old, still exist that require attention, focus and action. Scotland has always been a country that's innovated and excelled. I'd like to thank the Minister and her team for joining us, which is a great compliment to the conference, and thank you for coming along. But welcome the opportunity for us to recover and to innovate and excel. Thank you.
Thank you so much. And Dr. Ingrid Young made reference there to the various sessions that have been held. Fantastic sessions. They're all available on film after this event, so you don't have to have missed them. Now, it's my great pleasure to introduce Maree Todd, Scotland's Minister for Public Health, Women's Health and Sport. You're up in the West Highlands, yeah, Minister. But just a little bit of context here. You're a pharmacist by profession. You worked in NHS Highland for 20 years, mainly as a mental health pharmacist in a psychiatric hospital. And now you're in a completely different institution. Let's hear from you. And thank you so much for giving this talk.
Thanks, Penny. It does turn out I have some transferable skills, it has to be said. So, and thanks, Alastair. It's just lovely to be with you all this afternoon, even if circumstances mean that we're not meeting in person. It looks like you had an absolutely fantastic conference. It's really terrific to see the breadth of debate and discussion covered in the last few days. And I'm very grateful to have the opportunity to say a few words as you reflect on what you've heard and look forward to what we can achieve as we all move forward. So in particular, as we look to the future, I want us to take a few moments to celebrate some of the key achievements since the first Scottish Government Sexual Health and Bloodborne Virus Framework was published way back in 2011. We've achieved a huge amount, too much for me to cover in the short time we have here, so I'll focus on just two successes that I think are really illustrative of Scotland's strengths. Firstly, we should all be really proud of the strides Scotland has taken in detecting and treating HIV. People with the virus are now able to live long, happy, healthy lives, often without even the fear of passing on the virus. And that, of course, has been the work of 4 decades, and I am incredibly grateful to everyone who's fought with such passion and dedication to get us to where we are. I also want to take note of the progress we've seen in just the last decade, though. I'm sure you don't need me to tell you that in 2017, Scotland was one of the first countries in the world to introduce HIV Pre-Exposure Prophylaxis service, which was offering free preventative medication to those deemed at highest risk of acquiring HIV. The introduction was rigorously managed by a close collaboration of clinical experts, cultural groups, and people with lived experience of HIV. And its success is testament to that hard work. To date, over 4,000 people have had prescribed at least once, and we have seen a significant reduction in new diagnosis of HIV amongst gay and bisexual men in the 4 years since it was launched. PrEP isn't the only good news story. Only 2 weeks ago, I was delighted to see that Scotland had become the first country in the UK to authorise an injection to manage HIV, which can replace a regime of daily antiretroviral tablets. And that can make a huge difference to people with HIV by giving them a choice about the treatment that's right for them. None of this can be the end of our work on HIV, and I'll say more about that in a few minutes, but these developments are absolutely huge advances, and I hope that everyone who has worked to achieve them is as proud of them as I am. The second development I want to highlight is much more recent, but I think it also shows how Scotland is leading the way. Earlier this summer, the Scottish Government published the Women's Health Plan. It's the first of its kind in the UK, and it sets out priorities to improve health outcomes and services for women and girls in Scotland, and that includes sexual well-being. The plan has a comprehensive set of actions, but in particular, it aims to improve access to abortion services and better access to contraception. In both cases, we are taking the steps necessary so that women can get the help they need without judgment and when they need it. And we're already making progress in those areas. From next month, pharmacies across Scotland will be able to provide a 3-month supply of the contraceptive pill without a prescription, giving women who need it a short-term solution before they can arrange longer-term contraception. And we want to make it easier for those women to make those long-term arrangements as well. And that's why the plan sets out actions to ensure that women are able to access the full range of options available, including long-acting reversible solutions. The reason I've highlighted the HIV advances and the Women's Health Plan is because they demonstrate that we can only make progress when we work together. But they also point to something significantly more fundamental, that our outcomes are better when we truly take a person-centred approach. That's why it matters that people can choose how to receive their HIV treatment. And that's why a holistic approach to women's health has so much potential. While these illustrations demonstrate how far we've come, as ever, there is absolutely no doubt that they represent milestones, not the end of the journey. In the next decade, we have to challenge ourselves to go further. That might seem like a very daunting ask, especially when we're emerging from a pandemic that has left us with some of the most profound challenges our country and our health services have ever faced. And let me take a moment to say how grateful I am to all of the clinicians, carers, counsellors and support workers who kept and who continue to keep vital services running, even in the midst of these challenges. You've developed new ways to offer treatment, worked longer hours, and I know you've gone above and beyond to provide support to people who need it. I also want you to know that I understand that this work has been difficult, and that no matter how hard you tried, you couldn't protect services from the impacts of COVID. You're still short-staffed, you still have long waiting lists, testing capacity is still less than it needs to be. There are still inequalities in who can access services. There are vulnerable people who have been made even more vulnerable by the pandemic. I don't take these challenges lightly. They will take concerted and persistent effort to overcome. They will need all of our creativity and innovation and a desire to keep on pushing boundaries. But while they are daunting, I ask you never to forget the incredible efforts you made in the last 18 months. I am confident we will recover because I know that we are blessed with people who are passionate about improving outcomes for the people of Scotland and who will continue to work tirelessly and with exceptional compassion as we move forwards. And the Scottish Government will do everything it can to support you. Of course, the road to recovery will be long and complex. We've recently published a Reset and Rebuild, a recovery plan for sexual health and bloodborne virus services to address the impact of COVID-19 and to identify recovery priorities. The development of this plan was a collaborative process, and it couldn't have happened without the input of those who deliver and use the services. Again, I'm thankful to each and every one of you who played a part. With the help of our partners, the recovery plan will enable us to build on the innovations that have kept services going throughout the pandemic and to regain resilience in the future. To support this, the Scottish Government has provided £800,000 this year to third sector organisations, and we're in the process of allocating additional funding to support specific recovery actions focused on testing, HIV and Hep C elimination. Our hope is that by taking a period to focus on recovery, we will lay the foundations for that bold ambition I spoke of earlier. And those ambitions, if we can realise them, will be worth the enormous amount of hard work that they require. While there's much more work that we can and will do together, I want to briefly outline 3 priorities for the Scottish Government: drugs interventions, HIV elimination, and the next multi-year sexual health and blood-borne viruses framework. Turning to the first of these, we all know that we are facing a drugs death emergency in Scotland. We must urgently tackle the impacts of drug use and reduce deaths. There are no easy solutions to that. But those same principles I spoke of earlier, collaboration, relentless focus on person-centred care, those are the things that we need here too. And that's why in May 2021, we published Medicated assisted treatment standards, which are designed to help bring about consistent service provision across the country, and also to ensure that everyone has the right to access treatment that's right for them. Of course, these standards have to be supported with resources. And earlier this year, the First Minister pledged £50 million a year for the next 5 years to support vital interventions, including outreach programmes and better near-fatal overdose pathways. And that's in addition to £13.5 million allocated for alcohol and drugs partnerships, which includes funding to improve services for families in residential rehabilitation. Now, I can't claim that these initiatives will bring overnight success, but I hope that they will demonstrate that the Scottish Government and our partners are committed to a programme of meaningful and sustainable change. That is also true of HIV elimination. Work on a proposal for how Scotland can become one of the first countries to eliminate HIV transmission by 2030 will begin in the coming weeks, led by Dr. Rak Nandwani of the Scottish Health Protection Network. To support the work, the Scottish Government will establish an oversight group which will include clinicians, academics, public health experts, third sector representatives, and people living with HIV. And I am sure that by adopting a collaborative approach, together we can develop a proposal that is both groundbreaking and achievable. When it's published in late 2022, the proposal will contain advice on issues like target setting, outcomes, definitions, and building links right across the system to support diagnosis and treatment. It'll also consider options for widening access to PrEP across Scotland, but this will only be a first step. The hard work will begin afterwards as we endeavour to make its recommendations a reality. And even as we undertake this work, I'm mindful that HIV elimination represents only one aspect of the vast range of work that happens in sexual health and blood-borne viruses. To ensure that no one is left behind, we're beginning work to reinvigorate the framework on sexual health and blood-borne viruses. This has guided our work in this area for 10 years, and it's been a vital tool, but it's important that we take stock of where we are and update it so that it reflects current challenges and priorities. More and more, I think that means recognising that services for sexual health or HIV or Hep C or drugs treatment, no matter where they're based or how they're funded, must work together. That's what the people who rely on these services, who often have multiple overlapping needs, require and deserve. The framework can't achieve that immediately or on its own, but it must be a fundamental part of the work to develop it in the coming year. We're therefore establishing a programme board to oversee the development of the next framework update. It'll bring third sector, clinicians, academics together to ensure that we're considering the issues and the challenges in a systemic and a holistic way. And I want to assure you that this process will not be limited to just a few voices. Updating the framework must also be collaborative, and I hope that everyone here will help us to shape it. Now more than ever, it must be a framework that is capable of delivering real change. And that means listening to those who best understand what change is needed. As I said earlier, meeting the challenges ahead of us will take ambition and hard work. And I know that all of you possess those qualities in abundance. Our progress to date gives me every confidence that in the next decade, we will deliver sexual health and bloodborne viruses services that continue to transform the lives of those who need them. For the rest of this session, I look forward to listening and to answering your questions and to hearing your ideas on how we can do that. Thank you. Oh, you're on mute, Pennie.
Thank you. Yeah, my first job as a journalist, my first work was around HIV when it was emerging in Edinburgh in the early 1980s. And it is, when you reflect back, absolutely extraordinary that we are here now. It's so heartening. Maree Todd, do you think that there is learning that we have gained from tackling HIV in Scotland that is transportable, has wider application to this big question of sex and drugs in Scotland's health?
Absolutely. So I think that there's always learning to be had in every experience, isn't there? But I think that some of the work, and I agree with you, you talk about starting out as a journalist in the 80s. I started out as a pharmacist in the 1990s, early 1990s. And when I reflect on how far we've come in terms of treating HIV, it just is astonishing. And I feel hugely excited about the possibility of eliminating transmission and Hep C as well, two really challenging illnesses that we are going to manage to take the sting out of massively. We've already taken the sting out of them massively, and we're going to make so much more progress in the next few years. So I feel very, very excited about that. Do we learn? Yes. We have learned a great deal about patient-centeredness in this line of work. I think that, if I'm honest, I think all healthcare could take a lesson from the person-centeredness that's delivered in sexual health. I think that taking, all of the work that's gone on to make these incredible treatments accessible. We could do that in so many areas. We could take the barriers away in so many areas. I think we've a lot to learn from each other if we just open our minds and do it.
Yeah, thank you. Now, I think this is the first time there's been a gathering like this, a 3-day conference that has brought together sexual health and the drug work that needs to be happening and is happening across Scotland. Do you think that in terms of tackling Scotland's drug crisis, there's no other word for it, that we can draw learning from the targeted approach that we took towards sexual health over the last 40 years, as you said?
Yeah, so the work against the drug deaths isn't in my portfolio. Angela Constance has been appointed with a specific focus on that. And I think that's absolutely what's required right now. I think we can learn. So that focus, that relentless focus, I think is necessary to make progress at the moment. That, we talk, you can talk glibly about patient-centeredness or person-centeredness, but actually, if you put yourself in the shoes of a person trying to navigate the system, you find a bewildering array of bureaucracy and a lot of barriers and a lot of time spent waiting for access. And actually, if we can put ourselves in those shoes and sort out some of those challenges, it will be, and that's what happened in HIV, and that's what needs to happen with the drugs deaths. One of the things I mean, just last week we had a question and answer session with some of the people involved, and one of the people representing the families was saying, you know, what happens, what makes you think that this problem does not exist in evenings and weekends? And that's a kind of a very simple, straightforward challenge, that people are needing help at a time when services aren't open. We really need to be thinking about that and thinking about how to provide the services in a way that meets the need.
Thank you so much. There are so many questions that I'd love to ask you. We've got one from Julie Riddell that refers to the person-centered approaches, saying that they're obviously vital. Do you think we can address structural inequalities using that approach? You know, do you think that the inequalities thing is just so deep? Maybe we'll get time to move on to that later, but do you think person-centeredness is a key to unlocking some of this?
Yeah, because you start by looking at what the person needs, and some people aren't accessing healthcare at all. Yeah. You know, and that's why they're facing inequalities. So if we start with the person in the centre, rather than, you know, often, and you know, plenty of people have said it before me, often services are evolve with staff availability in mind, or, you know, a certain location in mind. If we were evolving those services with the person at the centre of them, then we would build them right, and we would build them to meet the needs of that individual person. And it's, you know, it requires a little bit of handing over of power, which is difficult to achieve in a system like this. But you know, that we need to do it, because we waste an awful lot of time and effort and money delivering services that aren't meeting people's need. And I'm confident that actually, if we were person-centered, not only would it be better for the people in the middle of it with all the challenges they're facing and a complex bureaucracy to navigate as well, it would be better for them. It would also be more effective, and it would probably be less expensive.
Thank you. There's one more question come in from Drik van der Hoorn. Can NHS sexual health services function when the UK nation's health services do not align with sharing data and records? What can we do about this? And if you would answer in 20 seconds, that would be wonderful. Thank you.
So I would say, so the challenge of data sharing is huge. What I would say, though, is time and time again, particularly since I've become a politician, patients and people who are using the services say to me, I wish you would take the same care of me as you take care of my data. So this is a challenge that we have to overcome. People shouldn't have to retell their stories time and time again, and we should be able to access a certain amount of shared data easily to better deliver what people need.
Bring on the day. Thank you so much, Maree Todd. You're going to stay with us, I think. We're going to hear next from a couple of people who are embarking on their careers in these vital fields. So to get their perspective, I'd very much like to introduce Lewis Clarke, who's based at Edinburgh Napier University. He's finishing his PhD in psychology, exploring psychosocial factors related to the human papilloma virus vaccination of gay men in Scotland. And you've recently, I think, Lewis, completed a research fellowship qualitative analyst role as part of the ESRC-funded Digital Intimacies project. That's quite a mouthful. Welcome to you. What's your take on what you've been participating in and where we go from here?
Hi. So yeah, I'm Lewis. Really happy to be here, and thank you for saying I'm back in a great career, because I'm really fortunate over the past few days to be exposed to such great minds. So I guess before I go into the main body of my little monologue, I guess I'd like to preface that I'm the son of a Jamaican preacher and a butcher's daughter. So if I rabble on too much, please just hold me back. So I started my PhD in 2017, and life is very, very different compared to where we are now. And I'm hoping it continues to be different in a really good way of where we're heading. So thank you all for giving me a great past few days of learning and reflection. So with saying that, I hope I'm not alone in being in awe and inspired by the variety of and robust discussions in the presentations across the conference. I often tell my students that whenever something new is learned and has sparked intrigue, to always speak to someone outside of their discipline about it. And I still do this myself, and I always like to take a barometer of lessons learned by talking to my dad. So as I said, he's a 60-year-old Jamaican immigrant living in Northern England. And if you were to say to him, his weeknights would be spent having discussions on things like the breakup cultures of teenagers, there'd be stunned silence, which isn't very common in our Jamaican household. So while it may not put me on any metrics with regard to research dissemination, some rather resonant discussions that we had included things like the CERT Scotland presentation and their key work on stealthing and the role of crowdfunding in research, or the work by Dr. Maree Todd and the e-resources their team created for facilitating resident sexuality and sexual and relational needs, or my own work on the ESRC-funded Digital Intimacies project. So what these and other presentations reflect is how important research as one dimension of understanding the health of our nation is. This has been written down in the Future Framework, where research and robust evaluation has been sought after, which further reflects how we can create a sound evidence base to inform future decisions, not only using quantitative measures of sexual well-being, but diverse forms of data that are essential for us to understand and know better how to respond to these key issues. So rather than listing all the amazing talks, which would take longer than I'm allotted, something that struck out to me, which really goes to the heart of the role of research players and has just been mentioned with regard to sexual health, is the role of the individual and the inclusion of our audiences in the research process. So utilizing co-production or other community-based participatory approaches has fostered an ability to allow research to be flexible, to allow research to be adaptable, for fostering feedback and meaningful discussions with patients and participants in informing research and how it's conducted. So it makes you think of conferences like this and networks like Irish, which allow researchers in all named forms across Scotland to come together, be they outside the academy and not just in a clinical setting, to sit in a lounge and network and start a conversation which can foster those synergetic relationships. So we can now more easily move forward where the walls of our silos are coming down and the relationships going on over the years, or beginning since Tuesday at the start of the conference, can blossom. And these can form relationships where we can just listen and learn from positions that we may not occupy, but can be engaged with and garner a new shared understanding of sexual health and blood-borne viruses. So again, coming at it from a PhD perspective, I thought I'd encourage everybody invested in sexual health research to take the responsibility for shaping the future of sexual health research. So I was fortunate enough to join Edinburgh APO when the incredible Sally Brown was there. And even though we failed to establish a working group with the acronym SHAG, she extended her time to me and fostered my engagement with the sexual health research community, which brought me to Irish and now to this very moment. So I ask everybody to take stock of their networks and potential new collaborators from this conference or beyond, and potential positions of agency and your ability to extend your hand and pull them up the ladder through collaboration or creating funding for new roles, which can foster a new generation of sexual health researchers like myself and Grace. So I opened this little bit with how I hope things remained different following COVID-19, and the impact of COVID has been voiced across the conference. And what I mean is the recovery plan presents this notion of reset and rebuild regarding sexual health and blood-borne virus services. So what I'm taking away from this conference, and perhaps promote others do too, is to take the awesome and inspiring work presented at the conference and challenge these terms and transform them into reflecting and reimagining of these services. I believe we shouldn't go back to the way things were before. COVID has taken a sledgehammer to some notions of health and to the perception and constructions of health institutions, and we shouldn't rebuild these in their former image. Instead, let's take the amazing new thinking that's currently being fostered in this fantastic community of researchers and collaboratively consider what to keep, be that telemedicine and consultations for contraception and early medical terminations, but reimagine these with the growing knowledge of issues that can affect these, such as the digital divide, or the growing understanding of the sometimes invisibility of privilege and how these inequalities can be overlooked or furthered by some new avenues of delivery. So I guess by ways of concluding this very rambly bit, I thought I'd end on a key ethos which I learned at this conference the other day, and it comes from the order of perpetual indulgence. So their central tenets as part of a worldwide order of queer people of all sexualities are the promulgation of universal joy and the expiation of stigmatic guilt. So beyond this Thursday afternoon, I beseech everybody attending to continue to educate, continue to advocate, and maybe do a bit of drag at the next invitation.
Thank you so much, Lewis. Clarke, if you want to put any questions, any comments, please use the Q&A column and we will definitely get round to them. But our next speaker is Grace Currie, who's at the University of Glasgow. She's a third-year medical student, sexual health activist, and member of the Board of Trustees of HIV Scotland. and uses activism both inside and outside the classroom to help make Scotland a better nation. Very warm welcome, Grace.
Hi, thank you, Penny. So good afternoon, everyone. My name is Grace Currie, and as it's already been said, I'm a third-year medical student at the University of Glasgow. So I have a particular interest in sexual health and well-being. I am a student, an activist, and a member of the board of trustees of HIV Scotland. My career and my activism is driven by my desire to make Scotland a healthier nation for everyone. Firstly, I would like to thank the Minister for Public Health, Women's Health and Sport for your commitment and support and for highlighting the key points raised throughout this conference. I firmly believe that health and well-being in relation to sex and/or drugs lives in people, not just spreadsheets. I think we can all agree that this has been a fabulous conference that has truly walked its talk in bringing together community members, third sector organisations, medical professionals and academics, industry partners and governments. I want to thank all of the community members, professionals and activists who have engaged in this conference throughout the sessions, exhibitor booths and Q&A discussions. Across the past 3 days, we've enjoyed countless and valuable insights into the ways that sexual health needs have changed throughout the course of the pandemic. I hope this leaves everyone inspired and motivated to be part of the next chapter in Scotland's sexual health and well-being. Lots to think about and lots to do. Thank you.
Yeah, thank you very much, Grace. It's fantastic to hear young people with such passion for these areas wanting to come and work in them to help us do this thing. But I wonder whether I could ask Lewis and Grace just a couple of questions. Do you think, let's start with Lewis here. Lewis, do you think that COVID, our experience of the pandemic, offers an opportunity to break the mold? In other words, the way it's been done. Is this our chance to do it differently now?
Yeah, I think something that comes across in my PhD research, which was before and during, and hopefully now could be considered after the pandemic, was how much health as the period of time we are now in has changed and how much it's brought into the social consciousness of the people we're trying to design services for. So it's almost now, if we go through the notion of co-production and the utility of our patients and participants in informing what research can be, there's no barriers to what our future culturally patient congruently aligned services could be now that if we hold them intrinsic to the future of our health service delivery.
Do you find that people want to be involved in the co-production of these things? Are they banging on the door to be heard and asked to be allowed in, or do you have to go and really drag the information out of people? How does it work?
I think especially for some of my participants, the value in their lived experience may not have been told to them, that what we could learn from them is so valuable. So sometimes it's harder to reach the people who could educate us the most, but it's down to us, down from as academics, as researchers, as the system, to pull in their knowledge and draw from that and let that inform what the future services could be.
Yeah, thank you. And Grace, there you are, you're a student listening to Lewis. I'm thinking, do we still have an issue to overcome here with stigma?
I think definitely. And as much as I'd like to say that that's not the case, and for the vast majority of people, they don't identify with any stigma, I think that there are still groups that maybe haven't received the right education and therefore still do have stigma within them. So I would really like to see that being reduced over the coming years, definitely.
Because, you're representatives of, a generation, a couple of generations back, at least from me. And the world, listening to what you've all been saying, the world has changed so much. Digital technologies, communication media, how important is it? I'm going to start with Grace and then go to Lewis. That people that understand how those systems are being used are involved both in the research and in the treatment, the outreach and treatment?
I think that we have such an emerging digital space, like everything is centered digitally at the minute. So I think there definitely needs to be more of a push to utilize that in getting the correct information out there to the correct groups of people. Not everyone is able to access services as much as we have a fabulous reach from what everyone is, but I do think everyone, or at least the vast majority of people, do have access to the internet. So I do think we should be utilizing that more. Yeah.
Yeah, thank you. And I'm going to put that same, question to you, Lewis. You talked, I think it was you that talked about needing to work in multidisciplinary teams. Techie people, for want of a better phrase, have got to be part of that, haven't they?
Yeah, I don't know if it's still a term du jour, but obviously there's early adopters to technology. But I think something that's definitely been discussed across the conference was this notion that digital isn't a silver bullet. We have to still be aware of digital poverty, the digital divide. So while there is this change to some services being online or being utilized as a mechanism to get people accessing services, we should also be aware of those barriers and how best to delineate them for the people that are still harder to reach when it comes to face-to-face services as well.
Yeah, thank you. I wonder if I could ask the Minister as well. You represent a very remote and rural constituency. When you're talking about involving people in your part of the world, how's best to do it? Is digital an answer? Here we are. We're at a conference where hundreds upon hundreds of people have listened and joined in discussion. That wouldn't have happened if everybody had to be in Edinburgh in the same room, or Dundee even in the same room on the same day.
So digital is absolutely part of the answer, and it's even more essential for people like us who may live, several hours from the local district general hospital. NHS near me was actually developed and evolved up here in my constituency because of the challenges of distances to attend hospital appointments. So, I think it's part of the answer, but it has to just be part of the answer. It needs to be used to enhance relationships, not to replace them. It needs to be part of the patient's choice. So the person in the middle of it has to be able to choose the means of engagement. And if digital doesn't suit them, they need to be able to find a different way to do it. But I would agree with Grace and Lewis, there are many people for whom digital would be a real answer. For someone like me who works away from home, to be able to access my own healthcare digitally would be ongoing, would be a real advantage for me. And there are lots of people in the same boat. It also, interesting things happen when you start to use digital. Sorry to go on because I'm quite.
No, it's great. Keep going.
But one of the exciting things that happens is that the power imbalance slightly changes. And there's, all those challenges with hierarchies and power imbalances that we have in the NHS. If you're sitting comfortably in your own home, in your own space, some of that falls away. And that's a powerful thing to happen. We need to explore it further. We need to understand it better. But, it's really important that people feel equal partners in their own health, and it's something we've been trying to achieve forever. So if digital can help us to achieve that, then that's a really powerful thing.
Gosh, it's terribly interesting, and there'll be a lot of learning from the very brilliant NHS near me, developed in the Highlands, rolled out across Scotland and now the world. So
absolutely,
let's have the same ambitions for this.
Pharmacists, of course, key as well to the concept.
Yes, absolutely, totally, without a doubt. And in fact, a rising, up the kind of pecking order, if you like, for want of a better phrase. Because one of the things that strikes me is that in the past, we would have said, oh, we've got to train GPs up, to address all this and refer people on. Now, can we develop a service that doesn't get funneled through the old bottlenecks, Maree Todd?
Yeah, I think we can. And you're right to look at the entirety of the healthcare workforce. So one of the things, to take pharmacists as an example, is that they are very accessible. They're often in places where health inequalities are felt most keenly. So utilising that pharmacy workforce to the fullest possibility, I think, is very, very sensible. It can't be the solution to everything, and the way that we access healthcare in the future is going to look different, but I would like to think it will be better. People will be, more empowered to look after. I'm a public health minister. I want people to feel empowered, and I want them to feel able to look after themselves and to access expertise when and where and how they need it. That would be my dream.
And Grace, as a medical student, does it hearten you to think that we can get out of the kind of old-fashioned silo mentality about who refers on, who does what?
I think that having access to doctors and medical professionals online is fabulous. I think that obviously there are some instances where you will need to see a patient in front of you, but I think that it allows for a lot more flexibility for patients because they don't have to think about how they're going to get from A to B. They can sit in the comfort of their own home, speak to their doctor. And in regards to sexual health and everything that surrounds that, although again, there will be times where it's necessary to go in for an appointment, being able to speak freely to your practitioner from the comfort of your own home. You don't have to worry about what anyone else might think if that is something you're concerned about. I think that it's a really powerful development that we've made.
Thank you. And Lewis, the point was made about data sharing, for instance. We really have to get our acts together on that one, don't we?
Yeah, and I think when we're talking about the future of health and what Scottish Health Service delivery could be, I think what health literacy means now has changed so quickly. A couple of years ago, I did an internship with the Scottish Government and worked on the health literacy policy. And now that's going to have to be completely revamped. We're going to have to get a greater understanding of the knowledge, skills, understanding of confidence of our Scottish populations with regard to digital health, with regard to the changes of where their services could be and what the digital mechanisms of those services will be in the future. So again, we're talking about change. We need to almost go back to the drawing board around what health literacy means now and accessing health services through all these changes because of COVID.
Yeah, absolutely fascinating. And if we can crack it around sexual health and drug policy, we've probably cracked it around an awful lot more in terms of Scotland's health. But you won't be, I'm conscious of the media debate around this, right? Of the desire to pull backwards, to go back to build back better, build back. Who wants to build back? Shouldn't we be building new? Grace.
Building new in relation to, what are we talking about, the digital space?
Well, just building new in relation to tackling these massive issues, sexual health, and drugs deaths in Scotland.
I think that we always need to move forward. So, obviously we can learn from the past and mistakes that have been made, successes in the past, but we're always looking to improve. So my only answer would be to move forwards.
Yeah, thank you so much. And Maree Todd, for you get the headlines across your desk every day. Have we got a mismatch here between the optimism and the drive and the forward-looking thrust that I've been perceiving around this conference and an outside world that might be saying, oh, no.
I would have to say, well, firstly, on your last question, I think the pandemic has shone a light on inequalities. Yeah. And they were pre-existing, but they've been exacerbated by the pandemic. And actually, I feel very strongly that Scottish Government has been elected with a mandate to tackle that. Like, Scotland's not willing to tolerate that anymore. We're not willing to turn a blind eye anymore. And I think that you will see progress on those issues over the next few years. In terms of, the energy, it's great that there is energy in the room. The pandemic has been a huge disruptor. Yeah. And there is no doubt that it's, I heard Lewis say we're maybe through it earlier. I suspect it has more to throw at us and more disruption to bring to us. So we're not quite out the other side. We're still navigating quite carefully through the midst impact of a global pandemic, which is difficult. But what we have learned from the last 18 months, if there is a silver lining, is that we can, when we need to, pull together and actually do impossible things. I mean, that's powerful.
Yeah.
We've now got a taste for doing impossible things in the Scottish Government. And I think it's we need to bring that focus, that emergency effort to a number of situations that we're facing, and then we can make progress.
Also, the successful initiatives in terms of COVID have been backed by a great deal of dosh. Is the Scottish Government willing to put the cash behind this that it's going to take?
I mean, I'm not sure which specific funding you're asking about, but is the Scottish Government determined to recover the health service? Yes. Are we determined to make progress in sexual health? And I talked about the excitement. There's tangible excitement about the potential of actually making world-beating differences in Scotland against HIV and against Hep C. And, of course we'll do that. It's within our reach. Yeah. It is literally within touching distance. So we'd be crazy not to take that opportunity.
Okay, thank you so much. I wondered whether Alastair or Ingrid wanted to come in with any comments at this point in terms of your reflections over the last 3 days, but also the challenges. How do we rise to them now? Alastair and Ingrid?
I guess for me, I mean, HIV is my gig, and as a tablet swallowing beneficiary of incredible NHS services that I've had to recalibrate during COVID, it's been a real game changer. I think, the thing that's happened is a rapid response in the drug space, certainly around homeless people, and in HIV recalibrating place-based services has been a game changer. Nurses and pharmacists have had to step into roles that they perhaps wouldn't have ordinarily. It's a bit like, we cannot send the woman back into the kitchen after working in a munitions factory after the war. It's the same thing here, maybe lessons to be learned from that. I certainly think HIV has been a game changer. In some ways, much as COVID's been hellish for many people, HIV was a game changer. It changed the power balance between the medical model and patients asking about side effects and alternative treatments. I think COVID is now going to force us to contemplate the health services and the health needs and seeking behaviours that we need to. And I'm really excited with the talent and the passion that we've had in this conference. Once you start writing it up, there's going to be a lot of policy asks, Ms. Todd. Prepare yourself. There's a lot coming your way.
I'll come back to you in a few minutes, Alastair, for the closing, and obviously Dr. Ingrid Young as well. But on these issues that we're discussing here, Ingrid, what do you think the remaining, big challenges are? Because we've got the vision, we've got the passion. Okay, let's have a look at what might come out from one side or the other and stop it.
I think one of the big challenges is are tackling those structural inequalities that they don't live within the field of sexual health, but they really affect it. So I think, how do we address socioeconomic inequalities, institutional racism, institutional sexism? These are big questions that we're not going to answer within sexual health services, but that we need to deal with. And actually, those inequalities exist out with the services. So a lot of work in sexual health and well-being happens outside the clinic. So we've been talking a lot about clinical services, but actually there's a lot of work that community organizations are doing that are tackling this. So it's about how is it that that community work can meaningfully inform the structural changes that we're talking about implementing. So that's what I think is our big challenge that's come out of this.
And that's part of recalibrating the power. Yeah. Who's heard, who's recognized as being around the table and who isn't. Let me read a couple of contributions that have come in. I've got 2 minutes before I have to hand over to Alastair and Ingrid. But Dr. Nicola Boydell saying, lots has been done to advance SRH in Scotland, but gains towards achieving sexual and reproductive justice are threatened by COVID-19 and an increasingly hostile environment in the UK. How can we work together to centre social justice? That's a really huge question. I'm just going to park that to one side and let it stand as a comment. about the difficulty of delivering genuine social justice. And another comment that's come in: if HIV home testing kits have been so successful, could other tests also work this way with access to specialists online? So in other words, you know, can we turn the process round that way? I'm just going to leave those questions sitting there while I hand over now. I'd like to thank all fantastic speakers. That was really tremendous. It goes faster now, doesn't it? And just to let everybody that's listening know, there's going to be an exit poll, and your feedback will really inform future iterations of meetings like this. So please, please do your best to let the organisers know what you think. And at 6 p.m, there is a Zumba session with Dr. Eric Chen online. So as somebody has exhorted me, get your lycra on and get down, get with it. So I'd like to thank everybody very much for taking part, and hand over to Alastair and Ingrid Young.
Just really from me, thank you everybody who's come on this journey into this rather crazy three-ring circus. It's been a great 3 days, and I don't think the conversation ends here. As we said earlier, Ms. Todd, brace yourself. There's a lot of information coming your way. Thank you, everybody.
Thank you, everyone. It's been fantastic. Enjoy Eric's Zumba class. We'll be in touch about next steps. Thank you.
And there's your poll on the screen there. So please, please fill it in, feedback, involve. And thank you so much. I'll say goodbye.
Bye-bye. Thank you so much.
Hope everybody's filling in their forms.